Well, good afternoon. Thank you so much for your attention, your invitation, Jason as well. Particularly happy to meet with the multidisciplinary people about here and to maybe assuage their fears about working multidisciplinary, because the rewards, I think, are enormous if you can get on speaking terms with your colleagues. I should maybe clarify from the start that I didn't set out to show long-term impacts of anything. I set out to show that maybe nothing was going on. And the reason I'm saying that is I was working, I saw in my environment that there was an extraordinary willingness of everyone basically to read papers and all that stuff that made a link between the later life health outcomes and what happened in the past, either if the people grew up or maybe even their mothers. So I thought this is very interesting that people want to engage with this, but if the science is so bad, isn't it worth finding out what actually could be going on? What would be the magnitude of the effect you could expect? Whether you could expect an exposure to be specific to certain ages of exposure, certain time periods, because that may help you understand maybe a bit about the mechanism, maybe a bit about intervention. So I was extremely highly skeptical, in part because I worked with David Barker initially to set up a Dutch famine study to test some of these hypotheses. So the only way to get a null result, to say it facetiously, is to design a good study. The better the study, the smaller the result you'll find, the more accurate also, because you cut out on the variability, the stochastic variability, you cut out on the false positive findings relating to chance. But in doing a large study, you will also be able to get a better sense of what it is you're looking at. So my idea was to say, let's find large-scale studies that have relatively simple exposures that speak to early nutrition, and I took early nutrition as an example of a total shock that would have stress, that would have nutrition effects, that is well documented in terms of the onset and in terms of the endpoint. So that to me is just a particular example of an experimental, a natural experiment that we can use to establish is anything going on, because otherwise there's nothing to explain. If you see something is going on, to say then you can say something specific about the relation between the exposure and an outcome. Then we had new technology emerging in terms of epigenetics, so I pulled in the lab people and say, can we find anything going on in epigenetics and in exposure? And then to put it together, can we make a story that whatever is going on in later health, in blood pressure, in diabetes, could it be mediated in some way by the epigenetics, even if we know that epigenetics in itself doesn't make you healthy or not healthy, and it's only one factor. So that was my background, and I was very fortunate in having fantastic collaborators, and I was very fortunate in having been exposed to social sciences and history in my other work when I dropped out of medical school, before I dropped back into medical school. So in the end it all makes sense for me, because I found a way to integrate my own interests. So I'm going to talk a little bit about natural experiments, give you some examples that the economists will be familiar with. Then I will talk about nutrition shocks as an extreme example of a natural experiment that could have a biological impact, because we know the direct impact of nutrition. I'll illustrate that by some studies from Sweden very briefly. The largest part of my talk will be about Holland, but then before and after we'll have examples from Ukraine and from China as well. These are all starvation studies. And then in the end I'll try and summarize our findings. So very simple Medical Research Council definition. It's not under the control of a researcher. It's not a randomized study, but we want to use these as a randomized study. We have many conditions that are similar to a randomized study, but we don't have control over the way the study came to be and how it was executed. A well-known example in medical area is the Vietnam lottery. So people were assigned to be in service or not in service based on their date of birth. I believe, I'm not from America so I don't know the details, but I believe it was the date of being born on an even or an odd day that would determine whether or not you were called up for service.
It was random numbers picked in 1969.
There you go.
We had a seminar about this topic a month ago, so keep going.
There you go. So you can imagine, this is as good as a randomized assignment. And then this example has been used extensively. Initially, I think for employment, labor participation, salary, income, mortality. That's an example you're familiar with. Another very nice example, I think, by economists is to look at the impact of a hurricane, to look at the vital records, and to pull together with some assignment of proximity to the hurricane, severity of the exposure, whether this would be related to birth outcomes. A third very nice example, Miriam Wust in Denmark, who took advantage of a very extensive program of child care, child service provisions that was rolled out in the 1930s. But because of financial constraints, it was rolled out step by step by step in different regions. So she took advantage of that design to apply her economic skills and to look at the health outcomes. And very recently I've seen a paper based on the similar exposure where she looks at reading scores and school outcomes. So these are all very inspiring examples from the economic field, and based on that there is, people have, I'm going forwards. Oh, I rearranged something. So taking examples from this, I thought that the natural experiments in nutrition would give me a very powerful model. We have 4 population-based large-scale famines that I examined. One is in the Nordic countries, where in the 1870s a series of very poor harvests generated big mortality in Finland, but not in Sweden. So with all the reservations, you can compare one country versus the other country outcomes. The second is a huge man-made famine in Ukraine, imposed by Stalin on Ukraine, where we have information about the severity of the famine by the mortality, and part of the country was not exposed to the famine because it was still Polish at the time. So we have a time series and we have a severity index, and we have troops at the border, Russian troops at the border, stopping people to go from an unexposed to an exposed area. So this was really a very brutal oppression of Ukrainian people, and very sudden onset with a poor harvest, compounded by the political intervention, and stopped maybe 7 months later. So we have a very rapid. In the Netherlands, also a famine at the end of the Second World War, with a very sudden onset because of the war situation, rapidly declining rations, and a rapid return to the normal conditions at the end of the war. In post-World War Germany, very poor situations. I'm not going to talk about this now, but after German surrender in 1945, the country was divided by the victors, by the US, by England, by France, and by Russia into 4 zones. So what came to be East Germany was the Russian zone, then you had the 3 other zones. There was enormous chaos, there was enormous nutrition problems, but the people in the American sector were much better off than the people in the British sector, because the Americans were much richer and could provide much more sustenance. So this potentially is a very appropriate setting, because you could follow up the boys who were born in these different sectors, and we have looked at their military records. They can be examined, except because of the situation, the limited access to follow-up data under German legislation, it's difficult. China is the third example I will mention. Extraordinary large famine also, Mao's greatly forward famine, millions of people who died, because the Communist Party wanted to Western monies and shipped a lot of their corn out to, I hear, Eastern Europe. I didn't realize that, but to foreign, and starved the masses in the process. This is for the epidemiology people, that we know a little about how economists deal with this, a nice overview, different experiments you could use. And in the table he talks about the various comparisons you could make. You're probably very familiar with these differences. I'm using a lot difference in difference methods, because I would have a non-exposed, a medium exposed, a high exposed region, and then I would follow the region through the famine and then get the region after the famine. So the difference in difference estimator would then say, all trends being similar, what is the added impact of the exposure, taking into account comparing the exposure groups in same time periods. All right, the first example, very simple. It's a large article, but if you compare Sweden and Finland, there's a dip here for births in 1866-67 who were born after a quick succession of harvest failures. Now, I didn't label this table, but you should be able to figure out whether the left or the right are the men and which are the women. So we have life expectancy at age 60. So I would say that the men are on the left because they have the lower life expectancy. So this would be the picture for the men, this for the women, because they have a higher life expectancy. The impact of the famine in Finland is more pronounced in the men, which we sometimes see. What's that?
I would have expected the reverse, actually.
Yeah, you would have thought that the women would be more susceptible. Sometimes it happens, yes. All right, we're back. I'm talking about Ukraine now in terms of famine, not in terms of telephone calls. But you can see from this map, this is a very strategic country. Sandwiched between Russia, Poland, the former Eastern Bloc, and Western Europe. And it was always considered to be part of the Russian Empire, and until the breakup of the Soviet Union, it was one of the Soviet republics. This is a map that reflects the level of mortality in different parts of the region, the excess mortality related to the famine of 1932-33. The famine was a 6-month very severe period, and then reverted to normal situation. The darker the color, the higher the rate of population decline. We have a 0 here because of provinces that were part of Poland and not affected. So with this particular setting, you can more or less, based on the population number, say I have people with no famine exposure, medium famine exposure, and you're making the jump that the excess mortality is an indicator of the degree of the famine. Subsequently, we also looked at the drop in births as an indicator of the severity of the famine, or we looked at population reconstructions that say the excess mortality. But the basic idea is that you take a country and have different regions and look at the various outcomes. This is for demographers, they recognize this, and in the western Ukraine, where with no famine, there's a very severe gap in the population. If you look at the census, the people who were supposed to have been born in 1932 are not there. They were either not born or they never survived. And in the other part of the country, we have an extra gap. So we have a Holodomor effect showing in the census at the population level. And we see it in the blacks for the men, and we see it in the right side for the women. So, looking for data, I was looking at a health outcome that would be established more or less across the country in older people. And Ukraine has a national health service, very good for the people, but also very good for me. And the National Health Service provides free of charge for diabetes treatment, insulin and oral diabetics. And it means that the people who are diagnosed with diabetes are referred to treatment centers, and their information is also collected in the National Registry. So the National Registry had about 45,000 entries at the time. And my thinking was that we would relate the number of diabetes cases in different regions, extreme, severe, of no famine, to the population at risk. Now at that time we could only look at the survivors in the census, so assuming that there was no selective mortality between birth and current age, the census data would give us the best estimate of the size of the population at risk. So these are really the survivors, but I took these to be an indicator of the births. So you'd say, how many diabetes cases can I find among the population that generated the cases? The people who were born in the same year, in the same half year, because we identified people from the census that had been born in a severe famine area, medium famine area, no famine area, in either the first half year or the second half year of any of the years 1930, 31, 32, 33 through 38. And what do we see? First of all, if we took the diabetes, this to be the reference, just to get an anchor, there's a seasonal effect. So depending on the season of birth, for any of the years, you have more diabetes later. So these people relate to the harvest, the availability of food. That season effect is exacerbated, but only for people born in the first half of 1934. And this has a certain relation to the red line that reflects the mortality in the famine. So we see the highest diabetes prevalence about 9 months after the highest mortality of the famine, which gives you a time zone that the exposure very early in gestation will translate into a long-term correlation, as I call it now.
So you mentioned to me before, Dick Steckel, in anthropometrics.
Yes.
You don't have wasting and stunting among these populations? Is there any?
Not for now. No, no, no. No. This is a subdivision of the picture I showed you in blue. The subdivision breaks out the regions with no famine exposure, where we see the zigzag season, the regions with an average exposure where we do zigzag, and the red ones are the regions with the high exposure. So the relative impact of the famine is the highest in those born in the beginning of 1934, 9 months after the top famine period. And the risk is about 1.5. So in epidemiology, this is quite a substantive risk. Unfortunately, for our testings, our internal validity, we see no difference in the diabetes pattern of those who are in the non-famine areas. They show the same pattern throughout the famine. So the next follow-up, we're working on, we had 1, 2, 3, 4, 5, 6, 7, 8, 9 oblasts. Now we're pulling in the entire country. We have a further improvement because we're not dependent only on the survivors in the census, but we have estimates of the births in each of these oblasts. So we have a population at risk, the births. We have the population of diabetes people, and we can relate that risk together. Assuming, of course, we have to say that the survivorship, we don't know anything between birth and, so we have to do some calculations as to how the survivorship could impact on the estimates. Would it dilute the effect, or would it make it an overestimate? Any questions on Ukraine? Then I'll follow that. Yeah.
Would you say something about how people managed fertility at that time? So if I viewed that there were, did people manage fertility, and could you imagine that people would have reduced fertility in light?
How do people manage fertility? In 1932, if they had very advanced birth control methods, started in Berlin in the 1910s and 20s, these are mostly peasant populations. And probably the number of children would be very important to work the land, so there wouldn't be any societal constraints on having to limit the number of children. But we see enormous drops in fertility by 50% in the famine period. So I would say to a large extent this is unregulated, uncontrolled fertility.
Okay.
Oh, yeah.
Is there a difference in, just like a generalized, who accesses the National Health Service in Ukraine? Like, if you were more wealthy, or would you be more?
Yes, yes. That's very possible. So you could do all kinds of scenarios, sensitivity scenarios. In order for this to show, however, if you have a time trend like that and a trend by the severity of the region of birth, you would have to assume that there were very distinct patterns in accessing the health services that only applied to those who were born in the first half year of 1934 in those particular areas. That would be able to affect your estimate.
Random access conditional on diabetes or not diabetes?
No, 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 no. Okay, I'll go to Holland, the larger part. Holland a little bit to the west. It's situated between Germany and England, geographically, also culturally. Holland was occupied by the occupied territory of Germany in the Second World War, and at the end of the Second World War the Americans and Canadians had advanced to part of the country, but there was a blockade of trains and foodstuffs because in reprisal for a strike by the railways. So the Germans did not allow any foodstuffs to be transported from the rural areas, and they didn't allow any coal to be transported. So in effect, this western part of the country was sequestered. People couldn't move in, they couldn't move out. We see that during this period the number of births declined very, very rapidly, and of course after the war there was a compensation for this, but this is at the population level a reflection of the impact of the famine on fertility. Holland had been neutral in the First World War, but prior to the Second World War in the 1930s, the government had put up a huge rationing system. They had negotiated with the farmers that the government would pay 70% of their grain, give them a good price for it. The other 30% they could keep and barter for themselves or sell on the black market or whatever, but 70% of the yield of the acreage would be under control of the government for redistribution. And at the end of the Second World War, the people received these rations on their redistribution cards. So we have those rations, and we see that if you divide the available foodstuffs by the number of people, then this is what people got at the very end. So that's another indicator of the access to famine. This is not bulletproof because there was a black market as well, but this is the big picture, and it was overwhelming. We see at the time the direct hit, especially among in the infant mortality, and especially among the men aged 70 and older. These younger ages are relatively very stable. And we can subdivide the different patterns in mortality in the different areas of the country. So we have the urban west where the famine was, and we have the rural areas. So we have an exposed and non-exposed part. So what did I do? I traced down 3 hospitals that still had records from the war. I pulled the records, I sent a letter signed by the head of the department saying, "Hello, we are interested in you. You were born in our hospital 70 years ago. Would you mind being interviewed because we're interested in how you're doing?" It was not so difficult to follow these individuals to their current address, but we only got, say, a 50% response because many people did not want to be interviewed. So the design here is that you have individuals born before the famine, during the famine, after famine, in the famine area. We don't have a non-exposed group threat. And the idea was, this is new, we have sibling controls. So for everyone we interviewed, we asked, do you have a brother or sister not born in the famine who is also willing to be interviewed? So matched. The women were asked about their sister and this and that. So we have a combination of controls. We have women who were exposed to the famine with an unexposed sister. We have women who were not exposed to the famine because they were born before or after, who also have an unexposed sister, right? So we have a double control to see if the patterns are the patterns that we attribute to the famine. Are they really famine related? Are they family related? Okay, so we have 1,000 people, we interview 1,000 people, we take blood work from 1,000 people. I guess I have to talk about this. This is a story about the birth weight during the famine, so it just makes the point that we can trace changes in birth weight during the famine, and the birth weights went down significantly at the very end, and then came back to normal very rapidly. But I will later show you data about long-term impact health-wise. And the long-term impact health-wise cohorts are not these cohorts, but are these cohorts. So these cohorts had something in early development that hit them, but since the country was liberated when it was still at the end of gestation, they recovered their birth weights. So we have that the long-term impact and the birth weight impact is not the same. So we're looking in men and women at various diabetes-related outcomes, impaired fasting glucose, glucose tolerance, both diabetes, and we see that the impact is a little higher in women, in the order of an odds ratio of about 2. We can also look at these siblings. So this is what I was explaining. We have famine-exposed men and women compared to their unexposed sibling. They're both 60 years old, close to 6. We look at body mass index, fasting glucose, 2-hour glucose, LDL cholesterol, triglycerides. And the famine-exposed have consistently less advantageous outcomes. So this is compared to a famine-exposed woman with her unexposed sister. And these are the double controls. In the men and women born before and after the famine, compared to their controls, we show nothing. So we're on to something in terms of diabetes. We have an excess risk of diabetes following up the 1,000 men and women. This is a little complicated. What I'm showing basically is that the glucose outcomes to our HOMA diabetes, that they are mediated through body size. So we think that the diabetes outcomes are not primary, but they're because the men and women are heavier. And as you get heavier, you have more chance on diabetes. So we think the mechanism may be obesity. That could lead to cardiovascular problems, diabetes problems, and other problems. And this is just a way to showing it in a formal, more statistical analysis. You can assign a number to the degree of mediation by different measures of weight gain, body mass index, waist circumference. And all these measures of weight have a substantive mediating effect on the diabetes outcomes. If you look at, so these are all on the pathway between the exposure and the diabetes. Next step. So we have diabetes. Now we have technology. We have epigenetics. And the interesting mouse studies, the earlier mice studies, show that if you fed a mother mouse, or a rat, no, a mouse, a rat, a mouse. If you feed the mother with a certain diet, the pup will change coat color. And the coat color change is to do with an epigenetic change. So the soy component of the diet can translate into an epigenetic modification. So this is, we talked about it briefly, whether the epigenetics are only changed in the very early period. This is an example that in pregnancy it happens. So you don't need to do epigenetic studies in terms of what happened. You can just look at the coat color. So the coat color is reflective of a mouse who is very overweight, prone to obesity, has brain problems, compared to a normal mouse. And yes, we talked about this also, transmitted, okay. So we said we have an animal model. Let's see if we can translate this into the famine. So we have a Dutch hunger winter, we have a biobank, we have sibling controls. Let's see what happens. So this is our finding. We looked at one IGF-2 APOE2 gene because that was well characterized. It's very well studied in cancer studies. We didn't look at the genome, we just had a little spot, and we were very lucky because our first shot was target. We're seeing the difference in the methylation of this particular gene. The methylation is the proportion of methyl groups on that spot can range between 0% and 100%. And I'm comparing the sibling with the exposure and the sibling without the exposure. And I'm reading out here, exposed minus unexposed, so it means the exposed are less methylated, depending on their date of birth. And it's to do with the date of conception, so they're systematically undermethylated. So this to us says we have an epigenetic signal after famine exposure in this particular setting. There's another picture where we do something similar and then set up the birth rate differences, and then we see nothing. Yep?
I was wondering, you were mentioning date of conception here, and you were mentioning also low birth weight before. Are there effects on preterm birth, or is it possible to know if people are small for gestational age? Or
No, there could be, but in Holland at the time, the proportion of preterm births was not very large, less than 10%. So any effects on that would not have an impact on this because it's just something happening in the margin. In addition to that, we have an estimate from other genes when we looked at is that the timing, the changes relate to the daily rations and also to the timing of the exposure. Putting it together, so we have a relation between the famine and diabetes. We have a relation between the famine and the methylation. So now we go into mathematics and modeling and all that kind of stuff, genetics, lab work, and we say try and get rid of all the false positives. Can we make a story that the methylation differences explain part of the health outcomes? So after all this filtering, we come up with specific sites, and this is looking at 450,000 different sites of the methylation, filtering out specific sites that are on the pathway between the famine exposure and high body mass index. And there are other specific sites on the pathway between famine exposure and increased triglycerides. So this is as far as we can go. We can make a big story about, oh, what do these sites have in common? Do they generate nutrition patterns? Are they tied together in some formative way? But that's something for others, I think, to further explore, because they can then specifically take some of these and say, can we generate body mass changes by methylation changes in these paths? But this is as far as we get, linking famine exposure to health outcomes and a possible mediating effect by epigenetics. Any questions on this? Another database in Holland that is super interesting are the military conscripts. At the time, every boy at age 18 was examined for military service, and the healthy people had to be called up because the Russians were about to invade Holland. We're talking after the Cold War, during the Cold War, early 50s. There was universal military service. So what we can do, we can look at the conscripts and see if their health exams, their obesity, their body mass index, their cognition was in any way related to when they were born, why they were born, outside the famine, inside the famine, before the famine, after the famine. And then we have large numbers. We have 400,000 military conscripts. I decided to not, for now, examine any of these who were born outside the famine area. Or that's not totally true. I focused on every conscript born in the big cities, before and after, and a scattering of controls outside, 25,000 total, because I needed to hand match these 25,000. I knew their military ID, but I had to get the military ID, go to the military, link this with their names, go to the vital registries, link their names to this, and then say, are they still alive, are they not alive? If not, what's their cause of death? So we focused on this. This is age 18 what we had, but I'm not going to, let me see, I can give you a quick slide, some report about, maybe 20 years ago there was an original report that at age 18 there were differences in the body mass index, differences in the weight of these 18-year-olds depending on the severity of the exposure. And then this is in preparation, but I thought we had to redo this analysis because at the time the definition of obesity was very different. We're now familiar to body mass index, obese, overweight, and there were some, I think, it was done with the analytic techniques at the time. There were no differences in approaches, there were all kinds of little issues. So I thought, since the data set is so large, we should really re-examine this. So the most common finding now is that there is some increase in obesity, but as you get to the extreme of the scale, the effect is larger. In other words, the impact of the famine is stronger for those who are more overweight. But the more important thing, I think, is the follow-up, because we selected our 25,000 births from these records, births in the same cities and births from unexposed regions, and we followed them through age 60 in the population records. These are the recruits, classified by where they were born, in the famine area, the south, the north, or elsewhere. So we have a number deficit in recruits at age 18 for those born 9 months after the peak of the famine, and we have an overshoot. So this is similar to the pattern we saw in the births. So we have a reselection of the births, and the reselection is to do with the prosperity of the parents. The richer parents have a less of a drop because they had alternative sources of food, probably. So in essence, we found differences in mortality in the recruits. We also compared the outcomes at age 18. It turns out that for people who had completed more school compared to people who had completed less school, their rate of survival would be 50% higher 50 years later. There was a strong social class effect. There was a BMI effect. But it turns out if you add the famine exposure to this, these effects were constant. So we have additive impact. The early birth hit, and then the factors that could have been a consequence but are apparently not on the pathway. They're independent predictors. Still okay for time, right? The third mass famine, millions of people died. In scale, this is much larger than Holland, because the mortality estimate for Holland is about 20,000 excess deaths. But the human tragedy, of course, is commensurate. But in Holland, what we have is we have a lot of detail about this small group, so we can do investigations in more detail and also examine the individuals and take their bloods. The dark parts are the areas with the highest famine. That in part relates to the grain growing areas, because that's where the grain that was normally available to the population that was shipped out. And in part it relates to the transportation mode, because if you were living in a grain area and there was a river next to you down to Shanghai, then that would be an easy and cheap way for the grain to be shipped out. If you were living in a more mountainous area, then it would be too expensive for the central authorities to ship out the grain. So this pattern is not totally identical to the grain producing areas, but takes into account the logistics and the shipping. Fantastic. So we need collaborations with transport specialists and historians to figure out what the actual patterns were, right, to determine exposure. Some areas not affected, some areas very strongly affected, and the time frame is relatively narrow. So we thought, what is going on in China? This is a very large number, and we have a lot of reports from China. The famine resulted in more overweight. It resulted in more obesity, in more diabetes, in more hyperglycemia, in more hypertension, in more metabolic syndrome, in more schizophrenia. So all of these studies that made a correlation between the famine and the outcome, they were basically all published because people realized, well, this is maybe something is going on. And then we thought, this is my student and I. We have to look at this because everything is just too perfect. And turned out in our meta-analysis that many of these studies had compared the famine exposed with the post-famine birth, so born in the early 60s. So you can imagine these are younger people. These are 5 years younger. And the diabetes risk among a 60-year-old is different from a 55-year-old. So we said, okay, let's go back to the published studies. This is not our own stuff, but these are published studies. We're going to extract from the published studies the number of people born before and after the famine, make our new tables, recalculate. What do we see? We're just showing how much of an artifact the age difference is from the choice of the controls, with the exception of one study in schizophrenia that showed an increased risk, but that had very appropriate age balanced controls. And then, as a synthesis, our conclusion was if you have age balance controls, then in essence these current studies are null. They show nothing at all. So in view of our information from Ukraine and from Holland, we don't believe this is true. So this is an example of someone like me saying, I can't find any data, I believe it's true, so my study must be wrong. My study must be wrong because I'm not good enough in defining the severity. There must be a mix of severity. I'm not good enough in defining the age of the people. If I did a good study, I would have to find something. So there's a big debate now in the papers between our group and other people, because we're saying you cannot say about the Chinese famine now on the basis of reported studies, because the studies are all flawed. They make the same mistake. It's not, maybe something's going on, we believe something going on. That should be a challenge to make better studies. some of the things we can learn about how to make better studies is to take our insights from Ukraine and from Holland and what we know about how to play with births and these various things. So that's a challenge. So the summary is that you need to have controls that are of the same age. I'll get to you. You need to have a good idea about the severity of the famine. You have to have some handle on the follow-up. And then you have, of course, the assessment methods of the outcome have to be comparable.
One of the things that is not controlled here is the post-natural experiment condition. That is, for example, one of the studies of famines that we did not list there, the Stalingrad. There's nothing there, but there's nothing there because the post-crisis period was as bad as it is.
Yes.
And in China, I think there's something going on of that sort. So perhaps if you could have measures of, which is probably going to be very difficult, of socioeconomic progress or whatever after the famine, or how quickly the normal bar was reestablished, perhaps that can help.
This is very true. We have a very simple way of looking at this and to say, are the outcomes different in the pre and the post? If not, we can maybe pool them as a common control. Some outcomes have very distinct time trends. More diabetes over time, so that's something that is also important. You can't compare diabetes in the 50s with the 70s, but in these particular instances, the window of analysis, it's only 5 to 7 years. You have a very narrow pre, during, post exposure. So I think your comment is well taken, because intuitively many of the famine research people, they would avoid looking at the post, let me try to get this right, they would take the post-famine people as controls, because otherwise the pre-famine people, they would have been exposed when they were young during the famine, in the first years of life, and intuitively they think this could be muddy the waters, right? And I think it could be true, but if empirically I see no impact of that, I feel justified to just put them together. So in summary, we have no idea, but we see patterns, and I think we see patterns with fairly, as best as we can at the population level, having very simple measures of exposure, very simple measures of outcome, patterns that are reproducible, that relate to specific outcomes, diabetes and obesity, epigenetic patterns that seem to fit on a pathway to do with growth and development. So the further development of these ideas, I think, would have to come from very specific studies, maybe in the lab, because we've used the population's armamentarium to point to something that is more generalizable than a rat study, right? So we're making a starting point for a specific focus on specific timings of the exposure, of specific impacts on epigenetics, and of course ignoring many things that go with famine. We're ignoring stress, we're ignoring other factors that may be related to the nutrition, because we're basically saying that these famine exposures are so extreme that they're likely to overwhelm the other factors. And the idea is that if you can show something for an extreme exposure, maybe there's some biological pattern that you can capture thereby. So the generalizability to people in non-famine situations would not so much be, can the famine do anything, but maybe other exposures could be related to changes in the epigenome that the rat model show. Is there a specific sensitivity? You could then focus on that, and as the rat people have done, use changes in the epigenome as an indicator of an environmental exposure. That has also been done, because you can titrate the exposure to environmental pollutants and then also bring about the changes in the fur color of the offspring. So there is something in the womb that responds to the outside world, which you can reproduce, which I think is a very important observation. Obviously, tremendous number of people helped me with this, so I want to acknowledge them in this final slide. If you have any questions, I'll be happy to take them.
I know some studies in the United States which have followed a lot of children, they would show that low birth weight turns out to be a negative effect, at least in the short run.
Right.
But it can be made up later on from other inputs, environment, parental, and so forth. So in other words, you can catch back up. Is there any evidence of that? Let's say in the Netherlands would be the place where I think you might be able to find that.
You could look at birth weight, because birth weight is available from, I mean, there's no central birth weight registry in Holland, but birth weights are universally collected. It all depends on how you think about birth weight, because you could think about birth weight as an exposure, as a driver of untoward effects. Or you could think of birth weight as an indicator, a peripheral phenomenon, an epiphenomenon. And in the second way of thinking, intervening on birth weight won't do anything. It would just be intervening on a by-effect of something. So what do you think of the by-effect then? I'm sure you know, I mean, many of the birth weight studies show very big correlations with social factors, with the prosperity of a family.
Yes.
There is a maternal genetic component as well, but the birth weight could be a reflection rather than a cause for a mechanism for intervention. So maybe in this audience I don't have to make a plug for interdisciplinary collaborations, but it's obvious that many of these insights, you try and put together insights from the history people, from the genetics people, from the biostatistics people, to get to a better specification of an exposure, a better specification of an outcome, and a better modeling of the relation between the two. So it's very difficult, because you have to learn to communicate with people from different disciplines, but I think it could be potentially very, very fruitful.
So I'd be curious, because you have strong thoughts about the quality of different kinds of work that have contributed to what we know about these effects, and I'd be curious to hear your thoughts about the transgenerational work that people are doing, with the logic of the germ cells are produced in the first trimester for the grandchildren.
Right.
And should that be something we pursue or not? And I guess the reason there's an underlying thing here, which is that in the social science, the logic that exposures are held in families across
Yes.
generations is a very important aspect of how we see inequality build and be maintained. And so I think there's some interest in this idea, but I'd be curious to how the empirics or your thoughts.
I think at the moment the biology people would be more tempted to say there is no intergenerational transmission, not in the sense that genes are transmitted. So you would have to, I think, look for an environment to specifically examine this. So the null, my null thinking would be no. Don't assume this, but maybe it's there, maybe it's helpful. So find an environment where you can look at this. Of course, the other consideration with epigenetics is that if you have a few hits, what does that mean in terms of cardiovascular risk for an individual? It could be just a distribution thing where examining thousands of people, you have a higher risk if you have a certain pattern of genetic or epigenetic characteristics, right? But how important is that in everyday life? And is that impact, is that neutralized if you are a prosperous person compared to not? So maybe the social factors are overriding or maybe aggravating the genetic differences. So I'm not an expert on how to balance this out, but I think in a discussion it would be very instructive, very useful to see if you can have some idea about the order of magnitude of these various effects, and then say, well, it's something that is driving, it's something that is peripheral, it's something that is additive, because that would maybe even help you steer your research program, right? Focus on the things that for your point of view are the most relevant. True. Jason. All right. Go ahead.
So when you were conducting these studies, one thing that I have difficulty understanding is what the counterfactual is.
Yes.
With these famines, is it systematic trauma minus the famine? Is it all the systematic trauma gone away? Is it possibly something else? And then a follow-up question to that is, does the counterfactual even matter from your perspective?
Well, it's easiest if you ignore the counterfactual in terms of the impact on the individual. But it's clear that it's not correct, because people have memory of famine. So there's a before and an after generation, and the after generation will maybe oh, if only you knew about the war. You say, I'm famine. I'm not. How can you be famine? In the war we had famine. You're hungry. So there's all kinds of inter-family responses that are based on the parents' internalization of the famine. So from that point of view, it's difficult to make a counterfactual, because you have to engage, incorporate behavior changes in the later generation. But you can, if you ignore those elements, I think you can make a counterfactual, because in demography you could express the mortality as the excess deaths that would have been expected had the famine not occurred, and taking into account changes in fertility and this and that. So that in a way is a counterfactual, where you express the impact not by the absolute mortality numbers over time, but by the mortality numbers compared to a model that has a postulated pattern in the absence of the famine.
In your methylation study you put up, you had this one hypothesis and you found something.
Yeah, we were lucky. What can you do?
Did it suggest follow-ups to, did it occur to you that this is a site to intervene on?
No,
That's the opposite, do you think? That
I don't think you can intervene on any methylation site.
well, on one hand, you showed you could, but
Well, yes. No, it's the on the fur. Yes, you can do that because that's a mechanism. So you have the methylation that has a particular impact on the obesity and brain cells and this and that. That's very true.
But for example, going back to the mice models and just asking experimentally how one could reduce or influence methylation on that particular location in rats and ask if that's then an intervene.
I'm not aware.
But did something stop, it sounds like you've already answered this, but did something stop you from, you have this site that seems to be on the path that you care about, and then what else might be affecting other diets throughout the life course and so on that might actually target the same mechanism?
Well, my sense from talking to the epigenetic people is that these patterns are very diffuse. So they correlate pathways, they correlate sets of methylations that work together towards risky patterns in terms of the nutrition. So it doesn't make sense at all. Why would you intervene on 10 loci out of the 450,000? What difference would it even make? So the illustration at this point, I think, is not so much intervening, but establishing that there could be a biological signal after a hit, and a biological signal is related to an outcome. So population-wise, there could be something. So we have to consider epigenetics as a potential mechanism, even if it's only pushing the needle a little bit one way or the other. And for that you need population studies, I think.
Okay, well, we will wrap up. Please feel free to join us up front if you have other questions for Dr. Lumey, and join me in thanking him for making a trip to Madison.
Thank you.